Medicaid or Medicare, and many have high healthcare utilization, there's also a very high prevalence of comorbid substance use. So these individuals overall comprise a very vulnerable population. And in addition to their psychiatric symptoms and needs, there's been a lot of work over the past several decades, including some work that I did with Don Steinwachs a number of years ago, that basically shows that persons with serious mental illness have a higher overall mortality rate than the rest of the population, and it's really mostly from cardiovascular disease, and only a very small proportion of that excess mortality is really attributable to accidental deaths. Although what we see in the paper, what we see in the news is very much homicide, suicide, but it really, persons with serious mental illness essentially are dying of the same thing as everybody else, but just at a higher magnitude. So this data is from Maryland Medicaid, essentially what we can think of as like a population-based sample, and compared to the general Maryland vital statistics, and we can see that these are the SMRs, the all-cause mortality rate is 3.5, and then if we look at the top causes of death, we can see heart disease, cancer. Most of the other ones are in the order of what they would be for the overall population, except for HIV, and we can see that accidental death is actually very low, and you can see that all the SMRs are increased. So why are people dying young? Well, unfortunately, there are many reasons that are what we would call somatic or not psychiatric reasons. All of the cardiovascular risk factors are increased in this population. So both the health risk behaviors, such as poor diet, physical inactivity, tobacco smoking, obesity is kind of a behavior and a risk factor, more a risk factor, and then the health risk factors of diabetes, hypertension, hyperlipidemia. So across the board, these are elevated about twofold. And then in addition, non-cardiac conditions are also increased. So this trial focuses on obesity. So I want to show you just some prevalence data so you can get a sense of the magnitude. This data is not published yet, but it's taken from the same trial. I'm going to show you what we did before we actually started enrolling people is we went to these different community mental health programs across the state, and we got oral consent, we had IRB approval, and essentially we weighed and measured everybody. And then we were able to take that data and compare to a matched sample in NHANES. And essentially what we see is that almost everyone at these centers was overweight or obese. 60% were obese. So it compared to 40% matched in the overall population. So it's just very prevalent. So why is this obesity so prevalent? There is physical inactivity, there is poor diet, but one of the main causes is actually psychotropic medications that people take. Almost all of the antipsychotics have some weight gain propensity, and the newer ones that have come out within the past 15 years have even more. And in addition, many other classes of psychotropic medications also cause weight gain. Actually, most psychotropic medications do. So it's this challenge because people may need these medications, but they have these metabolic side effects. And in addition, many in the population that were in this trial and that reflect some of those more seriously ill in the community take multiple medications. So it's not just as easy as saying, okay, we're just going to take one, switch one. So for this reason, I worked with Larry Apple, and he helped me think about what can we do behaviorally since the medications may be kind of a given, to work on weight loss strategies for this population. So I did get a pilot grant from NIMH to start this work before the trial, and actually some of the reviewer comments were things like, this population will not exercise, they won't get up, they're too tired from their medications. There was a lot of skepticism about behavior change, and these were from psychiatrists and people who were actually directly caring for these patients. So that wasn't too good, but finally I got the pilot grant funded. But in essence, there are issues that many in this population face that can make it more difficult for them to have behavior change. Many with schizophrenia, it is actually a brain disorder, and many have cognitive impairment that affects executive functioning. And many persons with schizophrenia also have persistent psychiatric symptoms. Even when they're, quote, optimally treated, they still have symptoms that affect their everyday functioning. And in addition, many have a lot of the same socioeconomic environmental risk factors for cardiovascular disease as other disparities populations, for example, racial minorities. So there's unemployment, low income, social isolation, and all these things make it more difficult for someone to lose weight, to go to a gym, to have healthy meals, etc. So our message that we had as we were trying to design an intervention was that interventions for this specific population really need tailoring. We can't take something off the shelf that's been used before, that was funded by NIDDK or NHLBI, and just go to the mental health center and implement this. We needed to do something to modify this. So what this trial was, we wanted to determine the effectiveness of a 1.5-year tailored behavioral weight loss intervention in adults with serious mental illness. And the setting we chose were something called psychiatric rehabilitation facilities. And what these programs are is that they're outpatient programs that provide classes for persons with serious mental illness and in an environment of rehabilitation. So essentially, they are generally nonprofit behavioral health organizations. In order to go, you have to have a prescription from your doctor. And once you are enrolled in one of these programs, you usually go at least a couple of days a week. They're usually freestanding facilities that have like classroom space, kind of like maybe like a small rec center. And they're kind of a cross between like a place you might get like vocational training and like an adult daycare. So they vary, but they may have like a pool table, they have dining rooms, and breakfast and lunch are usually served on site. So we thought, well, this is a place, kind of a communal place where some in this population go, and it could be a place where we could be able to interact with people to deliver a lifestyle intervention. So this is our trial design. Essentially, this is randomization by individual. We had 10 sites, and we collected weights at baseline, 6, 12, and 18 months. We had made our primary outcomes at 6 and 18 months for weight. This was also collected. Then on top of this design, we actually implemented something across all the sites where for each rehabilitation program, we went and had a standard protocol, and we advised them on how to change the menus or what they were serving for breakfast and lunch. So this went across all the sites, and it affected, obviously, intervention, control, and plus people that weren't even in the study. Okay, so we'll come back to this. This is obviously a design consideration to think about. So essentially, in order to be in the trial, you had to at least be overweight at one of these programs. You had to be at least 18. And essentially, we really tried to include everyone we could. We really only excluded people that had like a medical contraindication to weight loss, like if they had, some kind of end-stage disease, or if they couldn't walk, because exercise was a big part of the program. And then so many of the attendees at these programs had alcohol or substance use history, and many of them were in kind of ongoing, like, quote, recovery classes. So those people were included. We only excluded people, like, if they had a really active, like, they were condition, like they were showing up to the rehab program intoxicated or something like that. So we, many individuals did have, substance use history. So this is just to show you to begin to talk about some of the logistics of this study. This is ProHealth. I don't know if any of you all have been there. It's a clinical trials site in Woodlawn across from the Social Security building. It's Hopkins off-campus space. My study staff was based there, and actually ProHealth is very nicely set up for participants who come into ProHealth to get measurements done. They come on one floor, and then those in the active intervention group go to another floor, so there's good masking. The intervention, the data collection team doesn't know who's getting the intervention. Unfortunately for my study, we basically were going out to where the participants were. The only people that were at ProHealth were basically my staff. And then essentially we literally drove around the state, all the stars or all the different study sites that we had. We did it in a rolling manner so that we would go recruit and enroll at one site. Then the data collection team would leave, the intervention team came in, did the intervention, then the data collection team came back in to do the measurements. Just to give you an example, at our height in the study, I think the intervention was running at 8 out of the 10 sites because it was an 18-month intervention, and it was essentially a 5-year trial, but we had like a year or whatever to get started. Okay, so just to give you an idea of what the intervention was, for weight loss, I don't know how many of you are familiar, but we basically had kind of 3 components, or 2 really, weight management and physical activity. And the weight management essentially was groups, but also individual visits with our interventionists. And then on top of that, we had group physical activity classes that were 3 times a week. So there are a couple things to note about the intervention, just when we talk about considerations for that. We had trained interventionists leading this program. So we had our people that were at least bachelor's level, trained in motivational interviewing, going out to these sites, being there for when the intervention was delivered, and then leaving. The intensity of the intervention we modeled after studies in the general population. So normally we think of weight loss happening a lot in the first 6 months and then kind of a maintenance period after that. So we had more intensity here in the first 6 months. What we did for the exercise classes is that our goal was to leave, when we left the study, to leave something with the programs themselves. Since the weight management was done by trained interventionists, we didn't attempt to necessarily teach them, the staff at these sites, how to continue that. We didn't have the resources for that, but what we did was we trained the staff at the rehabilitation programs to lead the group exercise classes. We had a DVD that we created, and we taught them how to use the DVD and to lead classes, so that basically we kind of tapered off by the end of the study. Essentially, we had one exercise leader from our staff going once a week, and twice a week the rehabilitation program was conducting the exercise class themselves. Okay, this is just very brief, just to give you a general sense. There was a range in age. Most of our participants were younger than 60. 20 to 60 was the range. Many weight loss studies have mostly women, but we actually had 50% women, 50% men, 38% African American, reflecting the geographic and just the diversity of where our different sites were. We had, the average weight was 103 kilograms and body mass index was 36. And just to kind of show you, we had almost 60% had schizophrenia or schizophrenia spectrum disorder. And you can see here that people were on a mean of 3 psychotropic medications. Almost everyone was on one of those newer generation antipsychotics I was telling you about, most of which have propensity for weight gain. And then you can see here, just in terms of like the social characteristics, most people were not married, and almost everyone was self-described as disabled, and almost no one lived by themselves. Like, I think like 12% of the people did. And over half of people lived in like a structured residential program, either with a care provider that was paid for by like the state, or in a residential program that was run by one of these behavioral health organizations. And then the remainder lived with family. Essentially, I think one of the reasons why this study was thought of as being successful is because essentially we got weights on everyone. If we didn't get a weight on, there was one person that we didn't get an 18-month weight on. Everybody else at 18 months had either died or was censored for another reason, like pregnancy or going on dialysis. So we went and followed all these individuals to wherever they were, which we can talk about in a little bit. And then essentially, just briefly, we at 18 months, we had 7 pounds of weight loss compared to control. These are our main results. Doesn't seem like too much, but actually it is comparable to other long-term weight loss studies in the general population. And of interest, I think, is the shape of this curve. For those of you that are involved in weight loss studies, you know that in the general overall population, we often see this big dip at 6 months, and then people gain weight back. But actually, in this population, in this study, despite the intensity of our intervention matching that in the general population, we see that weight loss is gradual, but then kind of it's continuing. So I think this is, kind of, this says a lot, I think, about this population and kind of what we need to do with them.
That figure itself should be shown to those that said this group would never be able to do it.
Right, exactly, right.
They did better than in the power study.
Right, exactly, yeah, exactly. Okay, so now so just basically the summary is that, there are a lot of challenges in this population, but with this tailored intervention, people were able to make changes and achieve substantial weight loss. I think, now we'll get into the part that you all are probably more interested in, which is, what were our thoughts in the trial and what were some things that we went through. So, and I would like open this up to, if you please shout out or stop me, whatever, so we can have discussion. So one of the first things when we were writing the grant was, are we going to do an individual randomization or cluster randomization? We have these different sites, and I guess, budget concerns and just not being able to, have 60 sites was one reason why, we chose this. Chose to do individual randomization. It did make things more challenging for like masking the data collectors that follow up, because essentially you're going into a fixed place, and the intervention, particularly kind of like at the interim data collection points like 6 months, the intervention's still going on, and we have our data collectors there, the intervention might be running, and so we had to do a lot of things in terms of like the timing of when the data collectors went in vis-a-vis the exercise class, doing it in different parts of the building and things like that, so that we could make sure that our data collectors were masked, although weight is a pretty hard outcome to have a lot of bias with, but just in general, that was a challenge. Were you going to say something here?
But yeah, a comment. I mean, the threat for individual in that case is that there'd be leakage, that in fact it would attenuate the treatment effect. So if it did that, you have an even more dramatic
right. That's right. Yeah,
that's true. Than you would otherwise.
That's true. Yeah, that's a good point. I guess another issue that we did struggle with was this issue of trying to change the menus at the sites. We had done this in our pilot study, where was just a pre-post study, and it seemed like the sites wanted input about how to make their environments more healthy. We also felt that we couldn't, it was a whole commercial kitchen, so we couldn't just say, okay, we'll serve this food to the people in the active group. Like, it wasn't going to work. And we also felt that since they were getting 2 meals a day on the days they attended, we felt that in order for them to actually try to implement these behavioral recommendations that we were making in their real life, we needed to be able to give them some healthy choice, so that it was hard for us to say, okay, low fat dairy, don't have sugar drinks, blah, 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 and then have them have this breakfast with have 5 cups of orange juice or whatever. So we struggled with that. In the end, it worked out fine. Our results may have been more strong if we hadn't, tried to make these changes. And then I guess another issue, this was one that the reviewers came up with. Oh, sorry, were you going to say something? Yeah.
Yes, I have a quick question about
yeah.
What are some of the other outcomes you have mentioned?
Oh, sorry, I sort of abbreviated this because Kate told me to be short. I apologize. We measured essentially all the cardiovascular risk factors. We measured psychiatric symptoms, quality of life, health status, etc. We actually had a wide range. Yeah. Do you want to ask me about a particular one, or?
I'm just wondering whether all the other outcomes are showing.
Oh, right. We actually have, I'm still working on the other outcomes. We did see change in, self-reported dietary measures. You can take that for what it's worth in this population. We did not see statistically significant change in most of the cardiovascular risk factors, like those that would make up the Framingham score, for example. Most of them went in the correct direction with what I would call we don't say a trend to significance, but like a point, 0.1 or, something where it's looking like it would be good. I will say that many individuals, despite what I still consider to be overall low quality of primary medical care, et cetera, in this population, barriers to care, many individuals were on statins and they were on antihypertensives. And if they had diabetes, they were being treated for diabetes in the study. So very high risk, but also getting treatment. So a little bit hard to show, and we weren't powered for changes in lipids, for example. So a little bit hard to show with a 7-pound weight loss that everything, that the other kind of quote physical health outcomes would really change. Yeah.
How about their quality of life?
This is so fascinating. So basically, and I'm really kind of struggling with this in my ongoing work with this population, essentially the self-reported quality of life outcomes for this group in general, I think, are very challenging because people's insight and perception of their quality of life really varies. And qualitatively, and I'll show you a video at the end, and we're writing up a paper about how people felt about their bodies and their lives and their jobs and things like that really show that people felt better in the active group, but it's really hard to measure it with standard measures, even ones that are supposedly validated in this population. We really didn't see any change in SF12, quality of life, measured different ways. We have weight-related quality of life. We had, all these things. So I don't know, it's hard. Yeah. Okay.
Gail,
Yeah.
other than taking a smaller plateful, do the people in these programs have a choice of what they get?
Yeah, it really varied by site. It varied by site. Some of them were allowed to get seconds. Some of them, there were like a salad bar, like a sandwich or meat for lunch or something like that. But some of them was just whatever you served, you served. Some of them could go on a buffet, and some of them were handed a plate. So our recommendations were based on what they had at the site. That's kind of a separate analysis, but yeah. Okay. All right, so I'll just say that the reviewers were all up in arms about the psychotropic medications. What were we going to do about it? Would the psychiatrist be changing them because they knew the person was in the trial? Then people would come off their medications that had high weight gain propensity, and maybe that would cause them to lose weight and all this stuff. So basically, we were able to tell them that, we're not communicating with the psychiatrists. We will do sensitivity analysis. At the end of the day, there were only it was 5% in either group changed their meds, and it was not, it didn't affect anything, and very few changed their meds. Okay, but that was that was something that the reviewers are very, excited about. I don't know if anyone wants to talk about the analysis plan or not. Nayu Wang is my statistician.
Looks familiar.
Okay, so in terms of recruitment, so this is actually, I think, different maybe than some studies that are going on now, where I think there's a lot more like internet recruitment or kind of mass media type recruitment. Although I know that like maybe with the HIV studies or things like that, there is more clinic-based recruitment. But essentially, what we had essentially was almost a fixed population in each of 10 locations, where we would go in, we had a HIPAA waiver, so that we were able to talk with the rehabilitation program staff. We were able to meet people and talk with them initially without having them, to sign consent. We had oral consent to do these height and weight measurements, and we were able to really recruit people face to face, kind of like what I would say is like the old fashioned way. There are community meetings at each of these centers where all the mental health consumers come together. We presented there, et cetera, et cetera. So it takes a lot of person power to do that. So that's a challenge. It's not like you just, put an ad on Google or something. But at the same time, the advantages we had were that there was this defined population, and we had people on site, and our staff were able to have a partnership with these programs, and I think not only have success obviously in recruitment, but then kind of set the stage for when the intervention team came in later. Okay, and so just in terms of some of the logistics, yeah, go ahead.
I was just wondering, since most of these people have very severe mental
Yeah.
illness problems, and what you have to do with the IRB.
Oh, with the consent and everything, yeah. That's a good point. Yeah, sorry, I forgot to mention that.
Caregiver or something.
Right, no. So what we did is we have I don't know what you all do, but we essentially have a method of assessing whether someone is able to give informed consent. So we didn't use any caregiver or giving consent. Essentially, they have the consent form in the study explained in person. We have like, not just the consent form, but kind of like a flyer, not a flyer, but a page with notes in large print that people can, these are the take-home points. And then we have like a little quiz before they can sign consent, like, what are the what is the study about? What are we asking you to do? If you don't want to be in the study, who would you tell? What are the risks? And so if they don't pass that, and it's a separate form that's like goes into our database and goes into the chart. And so if they can't answer those questions, they can't sign consent. So some of what happened was that because we had the HIPAA waiver and we were able to talk with the rehabilitation program staff a little bit in advance, and because we had already weighed and measured a lot of the people through oral consent, we were able to kind of, if there was someone who clearly was not going to be capable to give consent, we in some sense could not avoid that person, but that person wasn't necessarily someone that we sought out to, recruit. And does that help? That's a really important point. But there are lots of vulnerable populations. So as long as you have a way that you're going to handle it. So basically, this study was very challenging. I showed you the geographic dispersion. Maryland's a small state, but we definitely had sites that were an hour away from our center. And then we had these windows for follow-up data collection where, you have to get the weight within a certain several week period. And we also, all the measures we did, all the questionnaires were all done in person. So not like giving someone a packet of forms. We did it all in person, all interviewer administered. So we would have our team just go on site and have their, kind of checklist. But in general, we only worked with each participant for a certain period of time because people did not want to sit for like 45 minutes with us. In general, their attention issues, plus we were working within like the schedule of the psychiatric rehabilitation program. So they didn't want like 10 of their people out for 3 hours, not in class, not eating lunch or whatever. So we had to, it takes strategizing on how to do that. So essentially we kind of go to these sites for a few weeks at a time, and we kind of just like incrementally move through the potential participants. We also use a 2-stage consent process. I guess I should have clarified that, where we have a screening consent initially for someone who's interested. Then they go through the baseline data collection, and then after that, they want to join. We do an enrollment consent, and they're randomized. So someone had to get through the screening consent, get through all the baseline data collection for them to be in the study. I mean, there's, about 2/3 of the people did, but some people had, medical issues or whatever, contraindications that they didn't. Okay, this is just a picture. It's kind of light in here, but basically the bottom line is we were not in healthcare facilities, so literally we were literally doing phlebotomy like in a laundry room, in an art room, anywhere there was a sink. We did meet like whatever standards, we needed to meet, but it wasn't like there was a clinic set up for us. We had bicycle testing that we did that was, we brought this cycloergometer from Deborah Young at University of Maryland, like in my minivan all around the state. Like this is definitely, in some sense, it definitely was not an international project, it was a Maryland project, but in terms of moving our stuff around, it was like at one point Larry Apple was like, maybe you should buy like a mobile bus or something, because it's like for all the setup and logistics and space that we needed, it was really a lot. Okay, and then we come to the issue of retention. So I think we did, it's not so hard to get people enrolled. Then once they're enrolled, we have to follow them for 18 months. And many of these individuals had been at the rehabilitation programs for a long time, but there's just a fair amount of transient housing, crises going on, contact information changing, and things like that. So we really tried very hard to follow people up. This is definitely a big challenge of working with this population, and I think one of the reasons why like prior literature in this and other areas has just not been as seen as high quality, because many trials will have like 50% follow-up, and there are all kinds of problems with that. We actually had a lot of home visits. So of the 200 and whatever 80 some participants at the end of the study, we had almost 50 home visits to get follow-up data. So it just was very labor intensive, but I mean worth it, but labor intensive. We tried to get multiple emergency contacts, etc. I'm sure you all do the same thing. So now in terms of the intervention, actually just like we had kind of some challenges and things that we had to do, we really worked hard to tailor the intervention to this population. Just as an example, a lot of our intervention was based off the Premier trial that Larry Apple led, and essentially we did a lot of distilling so that our messages were very short and simple, and we repeated a lot of our messages so that we were not making things too complex. We basically had several messages: no sugar drinks, drink water, eat 5 fruits and vegetables, avoid junk food, choose smart snacks, and choose smart portions for portion size. That essentially was like most of the curriculum of the entire weight management program. I mean, it was expanded, it was repeated in different ways, etc. But this is a lot of what we said. We just said it in different ways. Similarly, for the exercise recommendations, whereas in many other weight loss studies, you kind of get tips on how to do it on your own, we literally provided, 3 hours a week of exercise. So if you were attending, then you would get your exercise that way. You know, yes, it would be great if you did more at home, but you know, at least you could get most of it in through our program. And then for self-monitoring, which is one of the cornerstones of weight loss, instead of having a very detailed food and exercise log and calorie counting, we had a very, very simple tracker that we used for those who were able to, that essentially just mirrored pretty much what our messages were, and also added exercise in. The weight management groups themselves, there was a lot of repetition. We used motivational interviewing. We used rehearsal, role-playing, and essentially we broke down the material into very small units, and then we just kept repeating it every couple of months, so that people, you might spend like 4 sessions on beverages, 4 sessions on portion control, et cetera, and then like 6 months later, you're going to go through the whole thing again. But what we really actually found more beneficial, just anecdotally, than the groups was the individual one-on-one sessions that we had with the participants. We found those, we believe that those are more helpful. And then with the exercise, we spent a lot of time working on delivering group exercise classes to this population. I don't know if anyone here works in this field, but essentially the difference between like what you would get if you were to go to like a commercial gym and what we did was very, very different. So everything was very gradual, very incremental. The change in the steps, so like the cueing when you were to change like from one step to another was, it was simpler. We also worked a lot on people's like there was a lot of kind of people didn't feel comfortable exercising. Either they had never really exercised or they hadn't done it since they were in school. And so there was a lot of people not feeling good about their bodies, people feeling unsteady, and we really worked a lot on that in the exercise classes. And then in addition, there were a lot of issues to literally hold the exercise class, like figuring out where to hold it. Like I said, we were trying to get the rehabilitation centers to do some of the delivery. We had to identify champions at each site, then those people sometimes would leave. We'd have to retrain them, et cetera, et cetera. So that was a lot of work. So overall, we used a variety of recommendations for the intervention. We believe that these would not only be helpful for this population, but possibly other populations that are vulnerable or that have challenges in cognition. To speak a little bit to the environmental changes we were trying to make with the menus. Again, the sites had to agree to this in order to be part of the study, but there was a lot of variability site by site. So there might be buy-in from the high management, but that doesn't necessarily mean the person running the kitchen, who didn't necessarily have any particular training, was amenable to trying to make some of the changes that we recommended. Everyone was working within a budget that was pretty strict. Many of them used set vendors that provided foods at like different levels of preparation. They may have been required to use a particular vendor. And in addition, the food guidelines that these sites were dealing with were mostly put in place however many decades ago to ensure that people were getting enough calories and that the sites weren't getting, the federal food program, the sites were not like undercutting and not providing them enough food. It wasn't like they were put in place to ensure fresh fruits and vegetables or meat that wasn't fried, etc. So it was like working within all the constraints that the individuals had. And I actually have someone on my team who is a dietitian and had done work in the state of Maryland Department of health before, and so he was the one. We had one person essentially doing this part of the intervention. But and there were most of the sites were able to make changes. Okay, I have a video. Let's see if I can get to work. This is just from a couple of the participants.
The fact that you keep moving, and it didn't matter how you moved, and things were slow and catered to somebody that doesn't do things quickly or understand quickly. I like that a lot.
The Target food got an increase because I've been there, so I'm able to do the work easier. Like I can bend over easier now. And I'm more stamina from losing all that weight. I'm trying to cut down on my sugar drinks now because I figure out the amount of sugar in the drinks is bad for my diabetes.
4, 3, 2, 10 more! 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
So that's one of the participants leading with the staff member in the blue shirt's my staff member. The other person's a participant. So that gentleman basically is saying, like, he got a raise because he could do more, because he lost weight. He was able to move better. But it's hard to capture, it was harder for me to capture that like on a questionnaire, So in summary, people with serious mental illness are a really vulnerable population. They have an increased mortality and increased burden of a range of medical conditions. They really need targeted and tailored interventions to improve their physical health. Achieve was successful for weight loss, I believe in part due to our design and how we implemented it to maximize working with this special population in community settings. But there's a lot more, that we have to do for this population to decrease their health disparities. These are the people that I worked with, although I didn't list all the co-investigators and staff here. This is my contact information. So, yeah, I can take any questions or more discussion. Whatever you guys want. Yeah.
So, how do you think this could be implemented, on a broader basis?
Right, so that's a really great question. So we actually, I've been in touch with the Maryland Mental Hygiene Administration, which is the public, the public mental health system, and people at in the Maryland Department of Health and Mental Hygiene to try to figure out, like, kind of what do we do now. I think that this is very resource intensive. I think that one of the next questions is who should be, if something like this is going to be more widely disseminated, who is appropriate or who is able, to deliver weight management counseling, and who can deliver exercise. So weight management counseling, the question is, could a lay mental health staff, and many of the people at these programs do not have, many of the staff have like an AA degree. Many don't have bachelor's degrees, just as an example. Can they be trained in some version of this that would lead to dietary change? The exercise part, our group is actually working on both trying to make a curriculum to train fitness instructors to work with this population, and also to train people who are not fitness instructors but who maybe work at these mental health programs, not just to put in an exercise video, but to actually learn to kind of deliver an exercise class and then work towards some type of exercise certification, which there are many, many fitness instructor certifications, and they're not all equally weighted, but kind of like what's safe for someone to do. So, there's so much more to be done with this, and I'm working on it. I don't know how to, yeah.
Semi-related question. Did you learn anything in this study that would actually be helpful for weight loss interventions in a non-compromised population?
Right. I think that what we learned is that simplicity is really okay. and that working on like one or two things is really okay. I think that kind of anecdotally we learn that some of the characteristics of our study population, like persistence and some of the repetitive behaviors that people with schizophrenia often do, can actually be helpful in maintenance. So I'm not sure how that completely directly translates, but for example, if you listen to what people do, those that were able to change their behaviors often could continue those behaviors. I think that there was less choice available. There's more, less financial choice about where people go to get their food. So I think the whole issue of like, and this was sort of more of like 10 little microcosm environments, but like if you have a healthy environment where you're providing exercise and you make the meals healthy, like, you know, what can that do? I mean, there's a whole literature on like workplace exercise and nutrition and things like that. So I'm not sure how much that directly relates, but I think like, for example, Hopkins is doing this healthy beverage initiative now, et cetera, et cetera. Like if we, you know, what can we learn from helping to make our environments more healthy? I don't know. Those are some initial thoughts. I think, you know, obviously social support, I mean, some of that we already know. I think the idea if someone can make one or two changes, you know, certainly the high the high sugar beverages, the sugar beverages are just, for this population in particular, were so much a part of their caloric intake. And I think that if you know, have people that are consuming a lot of those kind of beverages, that can be a relatively easy way to help them lose weight. Yeah.
So I've got a question about the size of the effect, and
Yeah.
to just the last thing that you were saying about the sugary drinks, because a lot of these drugs, people have cravings
Right.
for sugar.
Correct.
And so the weight gain on olanzapine were, I think, like the 10 or 12 pounds per
Right.
month you were on it.
Correct. At least in the beginning, yeah.
When people's weight, you know, is shooting up in that magnitude and then continuing from that trajectory, it seems to me that the problem is very much upstream with the medical management. And, you know, an effect of, what was it, 3 or 4 kilos
Right.
at 6 months, that's, you know, perhaps not as big as you'd like with people who are putting on or have put on weight at that sort of rate.
Right. So I guess, I mean, this is sort of, this loss was in the midst of whatever medication changes they were having in the background. So these aren't like new people that are starting in a study and starting on olanzapine at the same time, or people who are already on olanzapine, and you know what I mean? And that, so this is just sort of with all the background noise of all the dose changes, which there weren't that many, of like, you know, the 30% of people who are on olanzapine and clozapine and all that stuff, we found this. So I think that, you know, I think that's good. I agree. This wasn't set up to, you know, many trials and many, you know, funded by pharmaceutical companies and things like that are set up to kind of either prevent the weight gain that these antipsychotics would cause, or get people to lose, you know, that amount of weight gain that they would get. And so we didn't really set this up that way. We saw this as more kind of population based. I mean, honestly, the trial was funded with a 4.5 pound predicted effect size. That's what they funded it for, just 5 pounds, I think, 5 pounds. So, yeah, I mean, I don't, you know, disagree with anything you're saying. I think that the whole issue of psychotropic medication prescribing is so important for this population. I'm not a psychiatrist, so I don't deal individually with switching people's medications. I think for sure, like, if you can get away with not putting someone on olanzapine or getting them off olanzapine, you know, that's what you would want to do. But I also think just, I'm not sure what your background is, but I think just in terms of secular trends, I think that there are less people on olanzapine now than there were even, you know, when the study started. I think people are shying away from it.
So The British and Dutch just did guidelines on typhus
Yeah.
bipolar disorder and launched a guideline on psychosis as well. And both groups looked at this trial, a number of others about weight management, and I think, agreed with your interpretation that the kind of writing off this population as a hopeless one is a real mistake, and that is a disservice to people. But both of those groups ended up recommending first that if people are rapidly gaining weight on
Right.
antipsychotics, they should be switched.
Right.
That should be the first
Right.
strategy. And that, the medical management that you're describing, where people are stacking up the statins and diabetes drugs and whatnot, it is not an evidence-based approach.
Oh, no.
To these conditions.
Oh, no. I was just saying people had high cholesterol and they were on statins. That's all. Yeah.
That's, a consequence of the medical management.
Right. I mean, I definitely think like this trial was definitely not set up to test, med switching versus behavioral management. And I think that I wholeheartedly agree and don't have any reason to disagree with, guidelines saying that should be done. I think that we need to offer this population the same interventions tailored specifically to them that we're offering, that are the recommended for everyone else in our country who's overweight or obese. So I think they would hopefully go hand in hand. I think also there's such a chronicity to overweight and obesity and the other chronic medical conditions, in particular in this population, so that we have, so many of the people in our study had serious mental illness for many, many years. So like if they were on a medication, you could take them off, great, but what are our kind of long-term strategies? And I think the long-term strategies at some level are going to have to include some behavioral programs, which is kind of scary if we think about the level of intensity that we had to actually deliver this to even just get 7 pounds. That kind of goes back to your question about implementation. Like, can a lay mental health worker with a few weeks of training from my team achieve this? I'm not sure. I worry, maybe that they can't, So, yeah, but that's a good question, so. I don't know what's that.
Did you have a targeted weight loss per individual?
Yeah, that's.
And did you also look at like the proportion who achieved?
Yeah, we actually, in the grant we did not, but we tried, we sort of, for each person, we had kind of an estimate of like 10 pounds. We just sort of like for their intervention goal, I took this slide out to try to make it less results-based, but we did have, in terms of the percent of people that had lost a certain amount of weight versus controls, I have to find this, oh yeah. We had, 38% versus 23% lost 5% of their body weight, 19% versus 7 lost 10%. But that was not a specific intervention goal for each person, like maybe in some other weight loss trials. These were just, it wasn't, like they were secondary outcomes. So, these are roughly comparable to like what other weight loss trials would find, not quite as strong. So yeah.
How did you define your disabling depression, and what was your sort of line?
It was really interesting. I'm really dealing with that with this new trial that I'm starting, where we're recruiting people from an outpatient clinic as well. But what we did with the psychiatric rehabilitation programs is essentially like if you were there, you had a serious mental illness. It actually made it kind of easy for us because essentially by definition, you had a functional level that, was allowing you to get these additional psychiatric rehabilitation services. But it's very, very difficult in these studies. I'm glad you asked it because essentially, these studies are so data collection intensive. We're going in and we're drawing blood, we're doing all these questionnaires, all this stuff in person. And for a lot of the psychiatric trials, they do very detailed diagnostic interviews where they kind of come up with their own diagnosis regardless of like what the chart says. And we did not do that for this study. We literally went in and we took a chart diagnosis, and we just, our view is that, you know, this is a population. It really doesn't matter exactly as much what you have, but that you're here. But I think that's going to be, it's challenging. And this other trial I have right now that's looking at overall cardiovascular risk reduction, we're recruiting a fair amount of people from these outpatient clinics who may not meet criteria. And it makes it a little harder for us to figure out like the best way to do that. Yeah. Is that this answer?
Yes, thank you.
Yeah. Okay. Okay.
Okay.
So thanks.
Well, yeah, thank you very much. That was very
Thank you.